welcome to the Nomad Dog Healthcare Stories podcast. We've got a wonderful guest with us today. We'll be talking all things digital technology in the healthcare space. The title of this episode is The Data Revolution in African Healthcare and Who Owns the Future. So I've got a wonderful guest with us and I'll let him introduce himself. Would you like to introduce yourself to our guest today?
All right, thank you. Pleasure to be here. My name is Dr. Simpa Dania. I trained as a medical doctor, but I've been doing technology for over 2 decades, largely focused on digital health, from way back. Currently, I'm CEO at HealthStack. It's basically a digital health infrastructure company for African healthcare organizations. And we're doing a bit to move the ministry forward. Thank you.
Yeah, you're being very humble about your background in health and technology. Okay, so we'll use HealthStack as a way to tell our audience a bit more about you. So tell us about HealthStack and what were the pain points that made you set up HealthStack?
Okay, so HealthStack. So HealthStack is like maybe the 4th wave of my journey in digital health. By the time I was rounding up medical school, it became clear to me that technology was what was going to be the bridge for healthcare to actually meet the mark, especially for this context. And we started way back, right? As we're rounding up med school, it was clear to me that technology was the bridge, right, to be able to bring healthcare to deliver its promise, for the population. And it was then, how do you do this in a manner that is contextualized, right? So the way it works in the West is not the way it will work for the African context. It's just a different ball game. And then I decided that that's what I was going to do. So I set up my company, and we started off first and foremost selling devices to medical doctors. So I would bring in laptops from the US and then sell some like pay as you go. So every month they pay me. So it's a subscription-based type thing, right, until they pay off. And we did that for a while, then went on to doing research, building research database, because again, that was the need, come with paper and all that. And then finally, we moved on. I think the first company was called Cyber Technologies. And then after that, we went into app maze. And then I took a break. And then, yes, I came back after post-COVID. To do HealthStack. Essentially, the problem has always been the same, right? Which is paper kills. So the initial building block for digital health, in my own perspective, is electronic health records, right? So we need to be able to provide care, on the digital platform, and so that's it. So that's how HealthStack started. Interestingly, for HealthStack, unlike the key difference was that I started writing code. So I basically wrote full stack. The V1 for HealthStack, which basically do things I thought I had learned from all my past experiences, and yeah, so that's where we are today. So today, HealthStack in itself is about 5 years old. So I started 2021, and so far so good. I think that those learnings are coming to bear, and some of the philosophies or theories that I had have been proved out at this point in time. But it's been a 20-year plus journey, but we're grateful to God.
Okay. So I wanted to just touch on what you said. You said you took a break. Are you able to tell us a bit more about what's inspired that break between the 3rd and the 4th evolution of your company?
So it goes way back, right? So at some point in time, Microsoft had noticed what I was doing, and I was in that Microsoft ecosystem. And they decided that so one of the ways to scale for us to kind of build and scale around that time was to have us be incubated essentially by a bigger technology company, Sidmark. I guess this is the first time I talked about this in public, right? So we were with Sidmark. So they invested in us, and I kind of was spending time in Lagos and in the office. And then, so as things would happen, I mean, fantastic guys. I have absolute respect for the Sidmark team and leadership. I think at that point in time, I was young and just cocky, right? I was just very proud, and I look back and I just like, we'll be in boardrooms and I'm like, no, all of us are equals. I mean, it's like 60-year-old people, these are people that are veterans in the IT world. Like, Number one, I don't know if you know, so there's something called NYC Online, YX Online, and this is a company that basically runs that. So that's the reason, right, they paired us with them, which was like we could learn from them. I mean, they've done amazing well with a SaaS product, essentially, in the educational sector. But I think I was just too proud. Obviously, at some point in time, it didn't work because we then started having boardroom clashes and stuff. It came to an end. Then just after I came to an end, COVID started. So it's basically started out that period. And I came also to realize myself. So I think the biggest learning there was that I found myself, and I found one of my biggest weakness, which was the fact that I was proud. And God dealt with me. I'm a person of faith. And so I had to take time so you break something, right? And you put it back together again, right? So it's those 2.5 years where it was challenging because in the midst of that was COVID, right? I mean, if you saw nobody that was talking about telemedicine before COVID, I was the one. I set up the telemedicine center at the University College Hospital Ibadan, ran the National Telemedicine Center program, ran the Pan-African program and all that. Then COVID happens. And God, in His wonderful ways, nobody remembers that Simpa talked about telemedicine. I didn't even get an invite. I didn't even get one invite to say, okay, come and talk. Oh, this thing that you'll be talking about, like now is becoming a reality. But it was just God, just like said, breaking me and then putting me back together. And I think I came back a lot more humble now, a lot more insightful. Yes. So for me, that was the break, and I probably gained some weight as well during that period.
I think a lot of us did during COVID. So I love what you said there, and I think that's something that most entrepreneurs learn in the journey, as you said. We all have to come in sort of dogmatic about what our convictions of the business and the industry we're in. And that process you described there, where your convictions are still the same, but your approach changes as you navigate that industry and as you navigate around the challenges, the people, and all these things. And as you said, it's better that we learn that quite early on than much later, because it costs you not just money but time and people and human resources and so many things are kindly narrated there. So I'm going to come back to HealthStack, and I want you to just talk about. So you talked about the fragmentation of sort of analog stuff and how that impacts patient healthcare. So I want you to talk about what does that look like on ground for patients and for providers in terms of healthcare fragmentation.
So I say this and maybe contrarian. The fragmentation of healthcare is only for the dreamers as a problem. Yes, I know, right? And because I lived that in my previous life. Right. I mean, I was a firm believer in connected healthcare. I say way back, 2000 and something, Microsoft had the connected healthcare conference. I mean, they were big pushing about that MCUI and stuff like that. I was in Seattle, for and all that stuff. But in the African context, it's not. We don't have systems. We will basically at that very base where people are doing paper. The provider is just trying to survive. It's trying to get a profitable business going. Like the last thing he's thinking about is that I need to be connected to my next door provider. Like, let me just survive. Let this practice just grow, right? On the other side, you have the patient, and the patient is in the power play across the divide. The patient is helpless, right? That's just the truth. I mean, it might sound right, but that's the truth. The patient is helpless. There's nothing he can command, right? He's at the mercy of, in fact, he's begging for attention, right? But that's very different from, say, like the US, where the systems are well established. There's now reason to build technologies like Lego, right? You've got to build or building a house. You have to have the foundation, and then you build the first level, and then you build the second level. If you go to the second level and you don't build foundation, it will crash. Right, and that's why, again, as something that's very contrarian, we all shout interoperability this year around the season. We talk about fire. We don't have system. We don't have the foundations. What are we connecting? Right, and so we're spending money preaching fire, but we're not spending money helping people build the systems. Build the system first; they can connect them. That's what happened in the US. There were systems that needed to be connected. That's why someone came up with fire. HL7 has been in existence for how many tons of years before we got to fire. I think interoperability has been happening at that level. The problem we have in Africa today or in Nigeria today is that we don't even have systems that are at scale.
Yeah.
When we have systems that scale, then yes, we talk about probability. I think that's a different way to approach the problem, and that I think that is uniquely African and contextual, which is build a large-scale system. We don't have the money, right, to build and then go and build a large-scale system. It's like telling Facebook that you need to interconnect with MySpace or any of the, or even TikTok, for instance. No, what Facebook did was scale massively.
Yeah.
Right, and I think that that's the approach that's cheaper and safer or time, in the long run.
So you highlight a few things there. The gap between what clinicians or healthcare providers are struggling with, which is just build a business, and then for the patients being hopeless in that, not knowing how to navigate the space, not having autonomy within the space. And there's that gap between the two, and how you bridge that. Is there a role for digital technologies to be able to bridge that gap? But as you alluded to, the building blocks in itself is not there. So would you say that essentially for the main players we have in the market at the moment, the way to move forward is to make sure that those main players scale and grow massively, and then look to interconnect with each other? Or is there an argument that all the small, organizations that are navigating this space just connect each other together and scale as well at the same time? Do you think that's possible to do that in parallel, or you think that becoming the big data companies is the way to go?
Yeah, I think that's the cheapest way to go, because you need to focus. Like, there are too many devils you're fighting in this part of the world, right? And that's the point. And so, like, right, I'm trying to set this stuff up where we're coming together and not looking at each other as competitors, but we're seeing how we can blend. Because, and I'll say this again, right? People might sound very contrarian. The healthcare market is not broad. It is deep, but not broad. So there's actually not a ton of providers that you have, right? So you need a big system. A big system solves the problem easily and faster. That's just my opinion, right? Small systems, it's just inefficient. I mean, I've seen it across board. Building a big system is very difficult.
It is.
Very, very difficult.
Yeah.
Right. And so it's you get to a point that you need to ask yourself, is it worth it? Like, I could be doing 1,001 things that are more profitable, both my time and money, providing better returns, than just trying to solve this problem that is not really anybody's problem.
Yeah.
Than my problem. And for me, it's also the point that we need to go back and sit down with the providers, right? Forget what your dreams are, and just ask, what exactly is your problem? And solve the problem with the provider first and foremost. And then you can then build your dreams as a second layer or the third layer on top of it. Dreaming first, it doesn't work very well with digital health. That's the honest truth. I just say that.
Yeah, and you're not wrong. We've seen so many companies come and go in this space, especially in the African healthcare space. And most only survive, under 5 years, if that at all. So I'm going to move on to sort of data governance, just because we've kind of touched on it in terms of scaling big digital health companies. Now, we already have this problem of data governance in other industries, and we still haven't cracked the nut of who owns the data. Is it the patient? Is it the healthcare organizations? Or is it the digital health companies? And who holds ultimate responsibility for making sure that that data is used for exactly what it is collected for, and it's not used, inappropriately? So let's talk about that, because that's the big question.
Okay, so let's talk about that, and let's talk about it from the point of reality, right?
Yeah.
So let's be clear. Patient owns their data, right? You've only extracted that information because you had an encounter with that patient. If that patient didn't show up, you don't have that data. So ultimately, patient owns the data. But in the power play, the patient does not have any say in that data. That's the reality, right? It's going to be very difficult to see how we change that. If you know where we're coming from, right? It says case notes, right? Medical case notes. This case note belongs to the hospital. It should not be taken away from it. I mean, there's a legislation that says, but it's over enforcement, right? So that's the play. Now, when you now go to digital health, so that data has now moved from the hospital, is now resident in a third party. That third party can do anything with that data without you even knowing. or without direct cost to you. So the question is, that guy a benevolent dictator or not? And that's the honest truth. I think that it's not a question of ownership, it's a question of access, because we can never really prove out that ownership play. I mean, I've spent money, I've built my system, you put your stuff in my system, now you're saying that you own it, I cannot touch it. Why? Did I beg you? You know, that kind of a thing. But it is, can we be fair to all the players so that whatever we do with this data, everybody benefits ultimately? I think that's the position that I would want to take. The other thing we can play around with is to say that the government becomes the parent for the citizens and should hold that data at the end of the day. That's where it would land. So because government they can enforce some things, they can not license you. They have the big stick, and so they can make a stake for that ownership because collectively that's what the government does, right? Work on behalf of the city, ideally, right? Work on behalf of the city. So that's why I will leave it, right? The government ultimately has the final say. Patients are helpless. Hospitals also finding out they're also helpless, the provider. But now that's dictating with whoever is owning the database at that point in time.
Okay, so I'm going to push you a little bit because obviously there's a little bit of a debate at the moment about digital health data governance. Because recently, a few African countries were approached by the US government and a few NGOs with regards for money in exchange for, well, this is how it's being positioned in the market, money to develop healthcare in exchange for digital registries that allows for monitoring, that allows for disease surveillance and things like that. And there's been a lot of debate about, you know, the data governance of that. Is that extraction of digital assets from the countries, which is worth a lot more than the money that's being offered? What's your view on that? And because you talked about the governments being the parent of this space.
So this is the point, right? It's the same thing that's happened to any resource that we have. Are you going to refine your resource or are you going to sell it? The beauty about digital health and digital health data is that it can be copied. Like, I can sell you anything. It doesn't stop me from having access and building my own stuff. It's not like oil. Oil can only exist in one location, right? Digital health data can exist in 1,000 locations at the same time and be as valuable as it can. So if they want the data, they can pay the price. It's the identified data. Give it to them. Collect your money. Hopefully you spend the money well. You don't win anything at the end of the day if you say, oh, you're not going to deal and you don't have the resources to build stuff. You will trade something at some point in time. It's that collected data. Now that's a different play, right? If it's just about giving you a copy of those of that, I don't think there's a problem in it. Like, if for some reason, like, you don't have like good cybersecurity systems and somebody takes the data, you will do something to get that data back, like, at the end of the day. So it's all semantics, right? The question is, the data that you won't have, that you're claiming that is yours, what are you doing with it? And how are you improving that whole system? So I think that just the tougher questions to ask and answer than whether we give them a copy or don't give it. It's a copy. It's not that they're carrying the whole database. And which was also funny, right? So I refer to Kenya. I can start a whole story on this. But the US government funded open source, and I had a big fight right around this because the open source community, as the way it was being pushed as being the only thing that the government can buy, was killing entrepreneurship on the continent, and that it needed to change. And that was like a lone voice. And then this happened, right? So once the USAID went off, the whole database broke up because it was somewhere else. It was belonged to somebody else. Somebody had funded it and all that, right? So you don't want that.
Exactly.
Own your thing, sell to anybody you want to sell, right? You put in resources to collect it. That's one way of monetizing it and improving the system, right? But don't let somebody else own your system.
Yeah.
So I think that's the critical thing.
So I really like that analogy that you used in terms of, you know, digital health assets being described like oil and refining it and how you structure it. I like what you said about refining it and then making it available, de-identified. And the reason I like that is because it kind of segues into the cybersecurity side of things. So from what you said, it sounds like the better way to go is that each country hosts and owns its own data. And in terms of monetizing it, maybe using other digital technology. So in terms of the cybersecurity side of things, making sure that the servers and
Yeah.
everything is secure and are national assets, basically. And then the access that anyone wants to that data is monetized every time access is given. And so you then, the governance of the
Correct.
data in terms of cybersecurity, in terms of what it's used for, in terms of everything about it, then rests with the government of each country. So, and I think the UAE is a perfect example of that. They have essentially used that structure. I don't know if they are,
Yeah.
licensing
Yeah.
their data to be used by other countries or by the pharma world or anything like that. But it seems like a good example in the market at the moment of a country taking ownership of its digital health assets and using that for the benefit of its citizens. Now, the pharma world is definitely one that would want healthcare data to develop new drugs, which, the argument is to benefit the continent, 54 nations that are very different. Where do you see the African governments galvanizing together and actually, through their sovereign wealth funds, using that to control their own pharmaceutical, should we say, destiny?
So I'll say this right, and it's sad, but it's a true reflection. Governments are not that effective. They have other priorities that are bigger than what we're talking about. And so I think that it would take a long time to get to that point where they see healthcare data as a resource that can be used and that is critical to the population and play the role that they need to play within that space. That's just the way it is. I can't say it. And it's also very difficult to orchestrate. And I'll tell you why, because of the sovereignty. So we say Africa, right? But Africa is 54 sovereign countries. And then when you come into it, depending on how that country is structured, so Nigeria is actually 37 sovereign states. If you look at it because healthcare is concurrent, right? I mean, the federal government says something does not mean that any state government is going to go with it.
Yeah.
We've
seen that reality for patients.
Yeah, so that's the reality, right? So you go sign something with federal government, doesn't mean that it's going to percolate to the state. I mean, we have multiple examples, right, across boards. So I think it's going to be difficult for that to happen, but maybe countries can build.
So, in your opinion, who owns the data collected in healthcare? Is it the patient? Is it the healthcare organization? Or is it the government? Should it be seen as a public good? Should it be seen as a public asset to be managed by the government?
Okay, so if we do a mapping of the stakeholders, right? You have the patient, you have the facility, you have the software company, and then you have the government, at least within that spectrum. Ideally, right, we'll say that the patient owns the data. But like we referenced, the patient in this play is very powerless, right? And that's the honest truth. That's the realistic truth. He comes in a powerless mode, right? The patient is sick, needs care, so he cannot demand too much, right? He needs to get well. That's a big priority. The hospital used to hold that data, right, in paper, and that's why you see on case notes it's written, do not take away, property of the hospital, whatever it is. But with technology, that has moved, right? So now the people holding that data is the software company. But ultimately, the software company is answerable to the government. And the government actually owns the people, right? That's why you say you're a Nigerian, right? Whatever country you are, it's the government that gives you that identity that you belong to this country. So you get a passport, you get stuff, right? So if you look at it from that framework, the government ultimately owns that data. How is the government empowered to do that? Can they, whenever they wake up, they can demand for that? Because even that entity itself is registered within a governmental system, right? It's responsible and can do stuff. And so, using parallels of this even within social media and the rest of it, where the government is calling the company to say, we need access to this. You need to create a back door for us to be able to look at what's happening on your platform and all of that. So I think that ultimately the government is the custodian, right? Because basically it acts on behalf of the citizen, should be custodian of that data at the end of the day. But they then have to be able to put in things, processes and an environment that allows them to exercise that right on behalf of the patient. But more critical than ownership is access. I think that the big issue to answer is access, not ownership, because Like, even if you own the data, you might not be able to do anything with it, right? The government cannot come out and say, well, we're going to sell the data, or we're going to mine the data, or we're going to do this. Everybody will go up in arms, oh, privacy, this one, that one. Government's not supposed to do this, they're overreaching. It's who has access to that data? How do we govern that access? And how do we make sure, ultimately, that everybody profits from that data? So it's a shared resource, it's a shared wealth, right? Essentially, at the end of the day, I think that's the way to look at it, right? Access, and the patient have access when they desire to have access. If there's money being made out of it, can the person that contributed that data profit, get a share of that funding? Imagine that, we're able to generate money from that data, and that comes back to being able to offer free healthcare, for the patient. That, for me, is more meaningful than saying, no, let me just benefit from the fact that my data exists. I think that's the goal. And for us, ultimately at HealthStack, that's the long-term vision that we have, that, if your data is within our system and any way that data is generating revenue, you should get that, and you should be able to apply that to your healthcare at the end of it. It's very nascent now, right? There's a whole conversation around whether that data is really what we think it's what.
Yeah.
But that's a conversation to have. I mean, I can tell you from my experience, we've had a couple of people approach us from India and other places to say, you know what, can we strike a deal? Just give us a copy. But, we're not doing that. I can go into all the reason why I don't think that healthcare companies should at this point try to sell data, but every man to his own cost.
Yeah. So I think you touched on a few things there. So as you mentioned, you think it should be seen as an asset and a shared asset between the citizens and the government, and that the profit sharing from whatever is mined from it, as you kindly described healthcare data being like oil, in terms of profit sharing, that should probably be how it would be. But then healthcare organizations will come in and say, well, actually, we're the ones who are paying for platforms for these.
Give them a share. Give them a share of it. Yeah. So we have something we say in HealthStack. This is community food. Right. So community food, right? That's what it is, right? Everybody gets a share of it, and everybody's happy, at the end of it.
All right. Okay. So I guess that's about, ownership. Then we can talk about the governance of it. The governance, as you mentioned, is kind of stewarded by the government, but the healthcare organizations and their third-party partners hold the responsibility for governance on it, right? Where do you think the patient can play a role in their healthcare data governance and the movement of their healthcare data governance?
Patient is powerless.
But we can't leave our audience thinking that people are powerless. I mean, the reason
no. So that's the point. So you see, let's be truthful. The patient is powerless. So the question is, if the patient is powerless, what can we do? If we don't accept the truth, then we'll build castles in the air.
Okay, so how do we empower patients so that they have some autonomy over how their healthcare data is accessed and how it's used?
Again, let me be truthful. It's difficult to do. So even if I say, each time you have access to the doc to my data, I need to give you permission, or you send me like an OTP and I'll whatever it is and give you permission. That's because somebody built a system like that. Your database is sitting somewhere. It's sitting somewhere else that anybody can just go make a copy of that database, and you don't know anything. That's the honest truth. So it's not, I don't think it's about empowering them. I can give you a copy of your data. You can go with it and say, okay, I have my copy of my data. It's just a copy. So once it gets into the digital world, multiplication is effortless. Or you can say, okay, you go and tie it to a blockchain. Somebody has to pay for that. And at the end, somebody owns that system. Somebody created that system that you're going to put your stuff on. So it's just an endless chase. So if we come from that point of truth, the patient is powerless. The question is, okay, what's the proxy to defend the patient? What's the proxy? For me, it's not even about defense. It's what's the proxy that the patient benefits. I think that's what should be. Let's benefit from what happens to the data that we give to you. On one side, the patient benefits in the sense that he or she gets care. Because if you don't give that data, you never get care, right? So that's one benefit. But secondary use of monetizing that, right, the patient should benefit. So we should make a case. And again, we're going to talk about how we as vendors come together and create that universal good and say, you know what, as a people, we're going to make sure that our patients get benefit from whatever we do. And we agree on that. And we would self-regulate ourselves. We can tell how best to self-regulate ourselves and to hold ourselves to that code of honor at the end of the day, and just kind of reflects also to like the platform that we're both in and we're trying to stimulate. It's one of those things that we want to push to say that, see, we are the ones that can determine this. It's not government. It doesn't always to sidestep government. Government does not have the power. They don't have the resources to enforce and to measure. Like, we're light years ahead of that whole process. But if we come together as a community to say patients will benefit, it's something that we hold ourselves to, then yes, we can execute that. But the truth, baseline, patient is powerless. It's the truth. See, economically, like for you to fight for your right, you have to be at a certain place economically. And that's the truth. So it's, if you achieve that, the guy that is struggling to leave does not have the extra energy to go and say that my healthcare data matters. And so I must be in the picture. No, he just wants to, like, whatever you do, it's not his business. But when you get to that point where economically you are stable, then there are other problems that you want to solve. We're not there within us,
so
right?
And I guess that's where, as you mentioned, the government being custodian steps in regardless of people's financial status.
I disagree. It's not the government stepping in. It's the collective of the vendors agreeing to a code of conduct.
Okay. But where you cannot guarantee that people will agree to that code of conduct, but will be players in the market, who else can take responsibility? Surely the government can play a role where they are regulating. And I hear you in terms of the government not having the bandwidth or the financial resources or the human resources to actually enforce these rules. But having them in place in the first place and being the player in the market, as you said, being the custodian of how that healthcare data is used, surely is one way to protect the citizens who may not be economically in a position to protect themselves.
So I think that the economically viable thing is for the government to proxy that consortium as a self-regulating body, right? It's a code of honor. There's nothing, and I'll be frank with you, it's just like saying that government should regulate cybersecurity. It can't happen. It can't happen.
Considering you mentioned cybersecurity, because that was going to be my next question. Many of the big players in the electronic healthcare records and healthcare space have been targeted recently. There used to be this code of conduct where, the people who attack systems kind of stayed away from healthcare data. That rule has gone out of the game. We've had a lot of systems that have been infiltrated. So how do you balance that in terms of code of conduct and cybersecurity?
It's warfare.
It is.
Right. And in warfare, there's no honor.
Yeah, because, especially when we move in a world where biological warfare seems to be the new, maybe not so new, but, the new artillery in the cupboard for countries that are at war with each other. If you had the biological, the DNA of most people in a country, you can develop a biological weapon that can wipe out a whole nation. So it's not a negligible threat. It's a real threat. And I think, part of what we were talking about before was the fact that some African countries have decided not to sign the new deal that was brought before them. Exactly, in terms of, and the exchange was supposed to be, we'll build better vaccines for you, we'll provide more drugs for you, we'll fund your healthcare programs and all the rest of it. And those countries have declined based on the sovereignty of how that data is going to be used beyond those things, because we know that the big pharma boys are going to come after it and they will be developing things based on that, and many of these countries will not benefit from it and would end up paying even twice as much for some of these drugs that are supposedly initially created for them in the first place. We've seen how with various pandemics and epidemics and things like that, where, quote unquote, I don't like to use the word third world, but countries who are not as economically viable end up being the last to get the vaccines, last to get the medications and things like that. Where's the balance?
So I think that it's warfare, right? And so you defend yourself. And you have to be strategic about defending yourself. So first and foremost, you want to limit external parties having access. You say that you want to do sovereign data. That's another play. But if you provide the resource to harden access, then you go the next step of making sure that you're maximizing your own asset. So like whatever we're seeing today, right, has happened before. So let's take the play with oil, right? You defend your asset. You make sure that you have indigenous people that are drilling for you as much as possible. The next step is that you want to ensure that you are refining yourself. So you need to be intentional, and this is like government. You need to be intentional about creating the right context for people to make use of that data and do stuff. Whatever country today is doing drug discovery from data sets and all that, don't have two heads. There's nothing special any longer, right? Especially with the world of AI. Information, knowledge is mobile. Like you can bring in people, you can build capacity, you can rent capacity, but you'll be building your own tools, you'll be building your own system. There's nothing that says any country in this world today cannot build or manufacture their drugs. There's nothing, it's just intentionality around it. We've seen that play out in India, we've seen that play out in China. So it's just intentionality. And again, this internationality, I must say, lies with the private sector, plus some enablement from the government. Government is a good platform enabler. Government is not good in executing most things. We just need to live with the truth and with the context and not assume that, like, people give too much credit to the government.
Okay.
No.
And are you saying that's specific to Nigeria or, African
Across
countries?
the world. I mean, there's something like a reference, documentary around the four men that built America. Private enterprise has been the cornerstone of development across the world. Even when China was going to transform, right, at the core of it is private enterprise. It's just that they had a strong government guidelines, like government was pushing that agenda. Government is an accelerator. That's what they're good at, right? But anything other than that, so it's about galvanizing the private sector, stimulating the private sector to do what they're good at, not government. That doesn't happen. So that change will come by private sector. It's for the government to enable that private sector to do what they can do. We've seen that. Look at Nigeria, Dangote refinery, NNPC refinery. If you look at those two powers, you can go on and just build from that. Private sector wins. There's no question about it. The president of the US was going to China. He didn't go with politicians. He went with the top breeds of CEOs of the country. How many would you meet that says that they're working for the government? Or they're expecting the government to be working for one private entity or the other? The reverse is the case. Here, we are government babies. Government is taking care of us. Government will do this. And that's why people will go on strike. Private sector is the key, is the engine for development.
Yeah, so I agree with you on that. But I wonder whether the reason why people rely on government in Nigeria in particular is because of the infrastructural issues outside of building your own private.
The infrastructure of the US was built by private entities. Why are we expecting to be different in Nigeria? Like railway system, private entity. Electricity, private entity. Oil and gas, private entity. We need to be able to trust private entities to do what they can do. Private entities are the best organizers of labor, of capital. That's just what it is. Like any other thing else is we're just deceiving ourselves.
Yeah. Okay. Well, let's talk a little bit about AI. So you mentioned AI earlier. How do you see AI changing healthcare data handling, interoperability, EHR systems? Where do you see its role? Because there's a lot of hype about AI.
Let me start with the biggest controversy. I think AI would substitute healthcare workers in Africa because Africa does not have enough healthcare workers. Okay.
Do you care to share an example of that, of how it will do so?
Have you checked the doctor population ratio for Nigeria? That's just doctors, right? I was making the example before. In my class, 300 professionals, less than 30 are in the country.
Yeah.
So we would never have enough healthcare professionals.
It's the same across the world,
Yeah, but because you
obviously the stats better
Yeah. Well,
elsewhere.
because you,
Yeah.
you have that economic pool, people who would go in that direction. So you hear things in the US about, oh, AI will support the doctor, will support the healthcare workers. For us, AI will replace. AI will be the one answering the call. AI will be the one attending to the patient because we don't have anything. The man in the village we call, the person that will respond is AI. So our question is, are we going to invest in AI? Are we going to build our own models and tools and all that? Again, that's a question for the private entities to answer, not the government.
Okay. So great, but I think you just said right on to a very important topic. If the AI that's in healthcare that's being built for the African continent is very different to the support tools that are being built for other high income countries, where is the safety in the system that's building those? So, who's building it, number one? Are they building it to local use? And where is the safety in making sure that those new AI systems that are being built are not going to cause more harm than if they were not present at all in the first place?
So, again, let's be realistic. So, first and foremost, I believe that African companies should build African AI for Africa. Nobody is going to solve your problem. Well, we have a problem currently in which we're a data poor resource entity to a large extent. We need to fix that first and foremost. If you don't have data, AI is just a pipe dream. Okay, so you fix that and you build stuff off of that. Now, classically, with any healthcare intervention, people will die first and foremost, and it is refined, and then ultimately it works well. That is the natural progress of things. It's not going to be any different from AI. I'm just saying that that's realistic. That's why you do drug trials, right? Because you're trying to control that whole process as much as possible. So the same thing should happen. You should have clinical trials, right? But that is done for the people, by the people. When we started off with the way surgery was done, people died till they found a better way to do it. So for me, it's just life. The thing ultimately is that there will be progress. It's just the same case that people talk today about life expectancy. Do you know that the life expectancy has actually improved for Nigeria over the past 2 decades? That's what the data shows, that life expectancy has improved. But that's not a good story to tell. I have to tell you that Nigeria has the worst life expectancy in the world. That seems like a better story. But just step back and look at the data. We're actually living longer than our grandparents did.
But I think when it's phrased like that, you have to put in some caveats to that. So,
But
the
that's
life
what?
expectancy, the life expectancy in Nigeria for men is 57. And that's very different to what it is across the world. Given the advancement of society, healthcare, technology, all of that stuff, you would expect that it would be much better than where it's at. So I think that's the other side of the story that needs to be told.
So that
I don't actually know about the improvement yet.
that is doing comparisons about 2 different places that have 2 different standards of healthcare system, that have 2 different forms of funding. What would you expect? There will be a difference, a remarkable difference. But I'm saying progress is being made. People are not looking at that fact that progress is being made. And if you don't celebrate what is yours, like, everybody will trample on it. People are living longer. That's the truth. That's what the data says. Yes, compared to other places, we're still worse off. 10 years ago, 20 years ago, we're still worse off, but we're getting better. So I'm pointing this out, right, to just say it's not the comparison between 2 different systems that is the issue. It's the progress that is made within one system. And how do you accelerate that progress? Yeah. And if you understand the parameters with which you work, you are in, then you're more likely to be truthful. And I come back and I say this because we touch on this, right? We talk about that issue around agenda and narratives. The more you look at this thing, the more you just know that, see, nothing has changed. As the world was before, so it is now, right? So it is now, right? So it was somebody's job to make sure that the ship that left Europe got to Nigeria and that trade happened. It is still somebody's job today that the narrative that we share is in a certain parts and in a certain perspective. The famous writer will say, the danger of a single story. We must tell our stories, and we must tell it from a place of pride. We're not there, but we're not where we used to be, and that's the truth.
And I agree with that. So I'm going to bring what we talked about back to HealthStack. So we talked about AI, we talked about data governance, we talked about cybersecurity, and all of that stuff, and being custodian of the data. With HealthStack, how do you embed trust in the business partners that you have and in the patients that use your service? What are the things that you do to kind of let people know that HealthStack is the organization to go for?
So the first thing is that we don't sell. We don't have a sales team. I think that's one of the things that's unique. I don't know whether it's by default. The second thing for us is we're trying to fight reliability and customization. So we don't generally say that, oh, this is not in our contract, we cannot do it. You want it, we will try and do it. And we'll try as much as possible to do it as quickly as possible. We're not always great at that, but we're refining our systems now to be able to do that. And to be able to make our system, like you would configure it to your own taste to meet you, what you want to do, how you want to do it, which is very different from what the other person might be experiencing. So our platform basically would digitize hospitals, we digitize HMOs, we digitize pharmacies, diagnostic centers. But it's still one single platform. The core of it it's what's there. It's just how you configure it that changes. So I think reliability is one. Two is customization, right? And being able to respond on time to it. The other thing is that we try and borrow credibility. I cannot say too much around that, but that's there. And the third thing I'll say, which is something that we're coming up with down the line, we want to support healthcare organizations to grow as business entities. And so we're evolving. So we call it a HealthStack community. I can talk about it. Maybe I can just mention it. So it's called a HealthStack community. And like, for instance, part of our year goal is to build 4,000 healthcare entities. I support 4,000 private healthcare entities across the country to be better healthcare organizations, more profitable organizations at the end of the day, run the systems. And so we're building the framework currently and recruiting partners to help us also do that. And we're doing that for free. We're not selling anything. We're not even going to hear, come and buy HealthStack or it's just, how do we help you grow? How do you help you become a better business? 80% of healthcare organizations in this country are mom and pop shops. Doctors that came out from training and felt, oh, I can do business. I don't know if you probably have read the E-Myth book by Michael Gerber, right? It's called the technician fallacy, where you think because you're good at doing something, right, then you'll be good at doing the business of that thing. And so how do we support them around the structures that currently exist? And like I said, recruit 4,000 healthcare organizations across the country, support them to be better in every way that we can, whether it's by providing education, providing resources, exposing them to opportunities to do better business at the end of the day. And the philosophy or the theory of change is simple. If they do well, then healthcare actually improves for the populace, and hopefully they will then have more money to spend to grow. At some point in time, they will naturally use technology. But the sell is, I've just found out over the past 2 decades, it's difficult to sell technology to healthcare.
Why do you think that actually? Why do you think that's the case?
Because where the market is currently is survival. And technology is a laggard in terms of showing improvement. So I make this famous joke, like if you got 5 million and you're going to buy computers and EMR system versus you buy an ultrasound, as a medical doctor that is running a hospital, what would you buy? You're laughing.
I'm laughing because I think
there's no
it depends on you. It depends on your growth stage.
English. You will buy ultrasound machine because you know if you buy the ultrasound machine, you recover the 5 million in 6 months.
But I don't think that necessarily holds argument. I tell you why. Whilst it makes practical sense to get the ultrasound because you believe that you can do your ultrasounds in-house and you're not sending people away, it doesn't necessarily bring you more patients. Whereas if your technology is tight and your operations is tight, you have leverage to make better profit and therefore have that financial flexibility to grow. So that's what I said.
You know how many ifs you mentioned? So those ifs are outside the control of the clinician, right? Those
They are.
ifs
Yeah.
are dependent on how that system has been built and structured. Ultrasound machine, the if of get more patients is within the control of the physician. He knows what to do to be able to attract more pregnant women to come. Put a signboard, get the word out. Now tell everybody there's a doctor. 9 months, you have consistent flow of patients. But we know, right, as system people, that if you put technology, ultimately you would improve the system. And that's why I talk about the problem, about our problem as dreamers in digital health versus the problem that the person who actually owns the clinic has. And until we're able to help him solve his problem, we should not think that we can solve our problem. It's a big paradigm shift. So I would ask you this question. How many healthcare practitioners in this short career of trying to build digital health system have you sat down in front of to say, what is your problem?
A few, actually.
Right. So
Yeah, a
that's
few.
exactly my point.
Yeah.
We need to go back and do, not for a few, but in thousands. We need to go and sit down with 1,000 practitioners. That's why we won't scale, because we're just trying to solve or trying to see how we can solve for a few. But if we're solving for 1,000, then there'll be trust. There's an aggregate to scale. And that for me it's tough, right? Because for you to do 1,000, you need to put resources against it. We don't have that resource. And again, it comes back to that community. If we come and we pull our resources as a community, then we can sponsor such things. We can do such engagement, and it becomes something that we all then use to build the right things and to solve the right problems for them and ultimately for the people. And ultimately, then we then make profit. So you need to put the clients first, right? And put them, it has to be done at scale. I think that's something that is lacking. But again, I can be wrong, but this is just my thought around it and how I am rethinking even what I have done over the past couple of decades.
What advice would you give to new founders who are coming in based on the experience that you've had? So 3 top things that you would say to a new founder coming into this, data, EHR, electronic record space. 3 lessons.
The first one is everybody that's gone before you is not dumb. You're not the smartest kid on the block. If the problem is not solved, there's a reason why the problem has not been solved. You're not the first person to think about it, and you just think that. And people forget this, and I'll say it again. The problem is not innovation in healthcare. The problem is skill. Hand washing is the simplest, greatest innovation for healthcare, but we're not doing hand washing at scale. If you can do hand washing at scale, you improve the healthcare indices of the country. So I think that's one. Be humble. Ask the people that have gone ahead, what is the problem? What are the issues? And then I think also in line with that is go and sit down, talk to 100, 200 hospital owners. Ask them, what is your problem? EMR, I can tell you this for free. EMR is not a problem of any hospital owner today. It's not a primary problem of any hospital owner today. It's a secondary problem, right?
What do you think? Yeah. What do you think is their primary problem other than increasing their patient footprint?
Money, workforce, at least. Those are the 2 primary problems. That the third problem is attracting patients.
I think you can solve all these 3 with technology, because there are some strengths. Yeah.
Yes, I think it can be done, but you need to be aware of that hope, of that problem, and you need to position your solution to solve at least these 3 problems. And you'll find that EMR is not the problem in this, but because we're stubborn people, we're dreamers, we just have that bug right? We hold on to the EMR and like, no, guy, you would install, you would implement. Okay, I would go and sit try and solve these 3 problems for you. But that's the honest truth, right? So those are the 3 things I think are critical. I may be wrong, but let's go test that out. Let's test this out at scale. Let's publish around what the problem of the private healthcare market especially are or is, and then let's work from that first principle and build the tools that solve those problems for them, and then we can move forward. The third thing I would say is this: don't start a startup because you want to raise money or you think you will raise money. Have in the back of your mind that you'll never raise money. Let raising money be an incidental thing. Healthcare is not a VC. Again, I can be wrong, but at least I looked at the data for me. I know of a couple of my friends, but healthcare is not a 10x return market. That's the honest truth, especially African healthcare market. 2, ain't nobody that's coming to buy healthcare startup. I had this dream when I was starting that, when Microsoft is going to think about coming to Africa to come and do healthcare. healthcare. I want to be the organization that we buy into. I calculated it. I will sell 20% of my company for X amount and I'll retire. Yeah, Microsoft still exists.
Well, I mean, I agree
You
with
know?
some of what you said, which is, healthcare is not your typical VC 10x business. But I do think there are some things, because you talked about scale being the main, barrier in healthcare. There are some things that bigger companies or the big players and the VCs can fund to help scale, maybe not necessarily to bring the 10x rewards that they need. And I think we've seen that with some things. Well, like vaccine technology, for example, like with pharma, for example, some of the small companies that started out quite small, but they needed scale to be able to produce enough for different countries.
See that, right? And if you think about it, it's because there's a buyer.
Yeah.
There's a buyer. Okay? If that buyer does not exist,
do you care to expand on that?
vaccines are not purchased by patients. The greatest buyer of vaccines is WHO and the likes of the global healthcare bodies, right? The Gates Foundation and stuff like that, because they have a philanthropic, to a large extent, initiative to see that people don't die. If you set up a vaccine production company because you're going to sell vaccine from a consumer point of view, the company will die.
I'm going to disagree with you on that and use the GLP-1s as an example of a vaccine. If you said today there was a vaccine for obesity, people will buy it.
The GLP-1 is a vaccine. That's a very tough call, right?
No, I'm not saying it is, but I'm saying if
it's a vanity drug. It's a vanity drug that is solving a huge, massive problem, right?
It is.
And so that's the point. So, see, the market must exist.
Yeah.
The market must exist. And you must have proven that you found a way to solve the problem before you pour in the money. So I have this philosophy of wisdom before money. Many of us want to use money to buy wisdom, rather than you finding the wisdom first and then taking money so that you can scale. It's the same thing, right? If you don't understand your market, there's no point raising money. If there's no money in your market, there's no point trying to take another person's hard-earned money and to promise that you will do stuff. That will not happen. Truth is truth. It might be hard, it might be difficult, but that's where it is. Who's buying technology in healthcare? Who's buying technology in healthcare? And who's buying it at scale?
I want to close out with a few questions. Where do you see HealthStack in the next 5 years? Because I think that in terms of success, what would be a success story for HealthStack in 5 years? Because I think that will paint a picture of where you see digital healthcare technology going in the next 5 years in Nigeria.
Okay, so HealthStack as an organization and in terms of product, for me, will be continental dominance, the OS of healthcare across the continent. If we can win Nigeria, that would be a big plus, first and foremost. So it's Nigeria first and then the continent secondly. But I think that a platform would help simplify healthcare access, administration, research, service delivery, payments, and all that. That's the goal. And for me particularly, people forget this. AI needs distribution. If AI is going to be the solution, it needs to rest on a distribution network. My prayer is that HealthStack will be that distribution network that lets anything that the future generation is going to build, the wonderful ideas that they will come with, they can plug it into a system and it will reach 1 million providers day one. I think that will be, ultimately for us, HealthStack exists so that people can live longer and that people can have joy when they encounter healthcare. Once we're able to do that, I think I don't think I'll be there in 5 years. I'll be on the sidelines. I retire next year to go face other things. So I've had a wonderful journey.
Okay.
Back, so.
Well, I like that, distribution network, because that's like building the Apple for digital healthcare in the next horizon. So yeah, that's a great note to kind of end on. So I want to say thank you very much for sharing your thoughts, for sharing your insights and your wisdom and your experience in this space. And I guess we'll say watch this space for all the great things that HealthStack is going to do and the galvanization of digital healthcare in Nigeria in particular and across the continent. So thank you, Dr. Simpa. And
You too. Pleasure. Bye for now.